Dear colleagues, dear participants, I'm honored to welcome you on behalf of UNFPA, the United Nations Population Fund, a lead UN agency working in the area of sexual and reproductive health and rights. Assisting countries in achieving the universal access to sexual and reproductive health by 2030, UNFPA has set 3 transformative results: reducing preventable maternal deaths, reducing unmet need for family planning, and reducing gender-based violence and harmful practices. Our regional office for Eastern Europe and Central Asia is based in Istanbul and covers 17 countries and territories, supporting the governments together with our partners to accelerate the progress in achieving the universal access to sexual and reproductive health as part of Sustainable Development Agenda and targets 3.7 and 5.6. European Society for Contraception and Reproductive Health is one of our key partners. Our work is guided by a Memorandum of Understanding and is focused on sexual and reproductive health and rights, including family planning. I would like to take this opportunity and to express our gratitude to ESC colleagues for fruitful cooperation, and in particular to Dr. Ali Kubba, Dr. Teresa Bombas, and Dr. Matthias Greutmann for organizing this webinar, which is tailored to the needs raised by the countries of Eastern Europe and Central Asia. Access to family planning, leaving no one behind, is a key area and principle of our support. As with reduced unmet need for family planning, we can reduce maternal deaths, unintended and high-risk pregnancies, unsafe abortions, and adolescent pregnancies, which are key challenges faced by our countries in Eastern Europe and Central Asia. As I already mentioned, ESC kindly prepared this webinar to address the topics which are critical for strengthening the national institutional capacities in the countries to ensure the provision of high-quality, rights-based services for each woman, each girl, and in particular to vulnerable groups. I believe this webinar will be interesting and useful for all participants. Thank you very much.
Thank you very much, Tamar, and I can add my welcome to the audience. My name is Ali Kubba. I'm a member of the ESC and I work in London. I'm going to share some slides with you to just take you through what we need to do during the webinar. But I wanted to first of all welcome everybody and say that this is the first joint ESC UNFPA webinar. And I want to thank Tamar and the team at the Eastern European and Central Asia Regional Office for their help and support throughout the memorandum establishment and running these webinars. There will be more news about the next webinar, which is in exactly a month's time from now. I think it is important to make sure that the topics that we put in these webinars are relevant to you, the audience, and especially to those who are working in the UNFPA region. So any feedback on suggestions on a future topic would be most welcome. So I'm going to now run my, let's see if we can get my screen going. Okay. Wanted to just tell you about the ESC. We encourage you to become a member. Membership is very good value for money. For 2024, it's 70 euros per year. Or if you want 2 years, you get a small reduction. When you join, you have free access to the webinars, to the journal, and I'm going to talk to you about Doc Matter and obviously other events. So we have regular newsletters. You have reduced Congress and event registration fees. So I can tell you that our 2026 Congress is going to be in Serbia, in Belgrade, and you have access to Doc Matter. Our aims as a leading society working collaboratively in Europe and beyond Europe, we champion evidence-based education and research in sexual and reproductive health and rights, including facilitating people's informed decisions in choosing and using contraception. And the talks today really address these two aims. Doc Matter is our vehicle. You can see the link here, and in which you can ask questions, you can submit comments, you can share information with colleagues. It's a community, benefits the ESC membership, and when you become an ESC member, you will be part of that community. For information on this, just send an email to info@ESCRH, European Society of Contraception and Reproductive Health.eu. As far as today, you can ask questions through the Q&A, not through the chat. So you click on the Q&A button and you will be able to essentially type a question, which we will endeavor to answer. If we can't answer all the questions, we will actually put them to the speakers, give you an answer, and publish it later. You can upvote each other's questions, clicking the thumbs up. It's very important that you use the QA function. There is simultaneous translation, so my very great thanks to Yuri Budinkov, who is going to provide Russian translation. You select the audio channel, Russian, in the lower function bar of the Zoom window. You can, as a matter of fact, if you want, also listen to the English audio at lower volume. This is the topic, and it is my great pleasure to be chairing the webinar. So if I could introduce our first speaker, Teresa Bombas does not need much introduction. She's the president of the ESC. She is a lead specialist in Portugal, where she works. She works also with FIGO and has been a very active participant in our webinars. And Teresa is going to talk about contraception in mental and physical disability situations. So over to you, Teresa.
Okay. Harry, I hope that you are seeing my slides now. Okay, I think you are seeing my slides now. Harry and Tamar, in the name of the European Society of Contraception, thank you for this webinar and for this work that we will do together to promote the sexual and reproductive health for all. It's my duty today to talk about contraception and mental and physical disabilities. I have no disclosure of interest for this presentation. I have to take this from here. And it's our agenda for today, an overview of a person with disabilities, the risk of use of contraception in this group of people, of persons, concerns about the use of hormonal contraception, health benefits, and take-home message. So what is disability? Disability is part of a human and integral of the human experience. And it results for interaction between health conditions and empowerments that a person experiences. So if disability is not a disease, could be a result of a disease, but is not a disease by itself. We have to respect the persons with disabilities because they are part of human diversity. And sometimes they are referred as a single population, but in fact, they are a diverse population with individual needs like all of us. Disability, as I say, is not a health condition, but a result of a health condition. So we are taking care of a different group of persons, and we have to do individual contraception counseling for that person, not for this group of persons. It's very important. So what we know about disabilities? We know that the number of people with significant disabilities in the world is 1.3 billion, and it represents 16% of the world population. And when you look for the WHO regions, we can look at European region, where we are, and we are the part of the world where the majority of the people with the persons with disabilities are living now. And we know that disabilities increase with age, but they are more frequent in women than in men. And when you look for the group of women in reproductive age, we have a huge number of persons with disabilities with special needs. The most frequent health conditions associated with disabilities, the four principles are musculoskeletal conditions, mental health conditions, neurological conditions, and sense organs conditions. So according to the women's rights, the people with or persons with disabilities have the same and equal right to the highest standard of health as many human beings, and we cannot forget that. So we have to promote sexual and reproductive health to all, including people with disabilities. So it's very important to change the language. We must focus on a person. We have Hannah with she needs of contraception, she needs of obstetrician care, she needs care on abortion, and she has a disability, physical, mental, she's blind, but the focus is Hannah is a person, has name, has life, has needs, and she has a disability. So what we know about persons with disabilities? They have the same age of menarche, and they have the same menstrual pattern like everyone. They have a sexual active life because disability not by itself is not obligatory that impact the family or sexual life of social life. And what we know about the person with disability is that access to contraception are lower, and they have not used sometimes methods that are suitable to them, and they have decrease of education risk, they have high risk of sexual abuse, sexual transmitted disease, and unplanned pregnancy, and deliveries in not good health conditions. So the reasons for that is because there are financial barriers, there are inaccessibility barriers. The systems are not inclusive because sometimes we as provider are not sufficient, we are not sufficient information for take care of persons with specific disabilities. Another reasons is cultural, religious barriers, and sometimes barriers related with the guardianship. Of course, as I said before, these barriers make problems and increase the risk of sexual abuse and unplanned pregnancy, and worse, the maternal morbidity and mortality. When we look at the methods of contraception, of course, the efficacy of the methods of contraception are the same with people, healthy people, and with persons with disabilities. But we have to take care to take in account that some women with mental and physical disabilities, the user methods could be less effective because they are dependent of the user, and sometimes it's difficult for these women with disabilities. So, but what are the contraception choices in women with mental and physical disabilities? Before we choose a method with the woman, it's very important to respect the woman's choice. So for us, it's an exercise. Sometimes we have to choose our language. We have to use other forms of communication like pictures or like translation or like interpretation, but we have to do our best. We have to take in account the mobility, the index massive, the other coexisting medical conditions, the compliance is very important, the other barriers, physical barriers, the interaction with other medications, other disabilities that this person could have, mental capacity to collaborate in the use of metal, physical capacity to collaborate in the use of metal, capacity to recognize the side effects of the methods, the needs. It's very important that in that group of persons, we look from health benefits of the use of hormonal contraception, by example, and we cannot forget that the persons with disability that can give her consent, they must give her consent, and if it's not possible, we need the consent for the parents of the people who take care of the person with disabilities. So let's focus in for the first step in the related risks. When we look at different methods, and this is the first slide for the daily methods or menstrual methods. So when we look at methods, combined methods with estrogens, we have to think about that the people who have reduced mobility and stay a lot of time immobilized, they may have increased risk of VTE. So we have to think about this is not the first line of methods, oral combined contraception, patch or vaginal risk, but we can use with no risk POP if they wish use POP. We can use with no risk injectables, but we have to think about the age and the risk because these methods can increase the risk of osteoporosis. So we have to use precautions in persons with reduced mobility. Sometimes the persons with reduced mobility, they are obese. We know that obesity is a cardiovascular risk, and we have to avoid. It's important to think about and use other methods with not combined methods. So maybe the best choice of the first choice will be progestin-only methods. And we have to think about other risks related with use of other medications. This medication can affect the efficacy of hormonal combined methods, and this is true for oral, patch, vaginal ring, PO only methods, oral and injectables. When we go to long-acting methods, it's quite easy to use in some of the persons with physical and mental disabilities. There's no risk in use implant in persons with reduced mobility and in persons that are obese. And in the majority of the persons that are using medication that are inducing enzyme medication, there's no effect on implant because the level of etonostrel are higher than the level that we need for contraception. So they are safe. The same condition for the intrauterine copper, the intrauterine device with no hormones and with hormones. So they are safe methods for people with mental and physical disability. Let's focus on medication. And as I said before, we have to look at medication that these women are doing, and we have to select the best methods for this woman. And if they are using a lot of medication, it's better to think in a low-acting method because the risk of interference on efficacy are lower. We have concerns. It's different from risks. Concerns are situation that we have to individualize the counseling. And when you think about the daily methods, we have to think about if it's possible to use a daily regime, if the woman can swallow the medication, and if the woman can deal with bleeding unpredictable pattern. And this is true for oral, POP, and combined oral contraception. With the patch, it's easier because it's a week, once in a week administration, but we have to think about skin irritations. We have to think about concerns about these patients of these women that are prone to picking and maybe place the patch in other place that is not easy to assess. About the vaginal ring, we have to think about if the self-use is possible and if the woman wants to deal with a strange object in the body. And we have to think about women with physical disability if they are able to insert and to remove the vaginal ring. The advantage of these combined methods is that the bleeding pattern is, we can prevent the bleeding pattern that is very good for some of these women. And of course, the injectable, we have to think about that it's more independent, but women have to come each 3 months to our service to do the injection. We have to think about and discuss with the woman the bleeding irregularities, and we have to discuss the woman about some potential weight gain. And weight gain may be limit independence for the women that are not so easy, not have so easy mobilization. Another concerns related with long-acting methods, of course, the implant, the woman have to accept the strange presence of the implant in the body, and for some women with mental disease this could be a problem, and we have to think about it. And we have, of course, to deal with the technical insertion, and sometimes we use other opportunity that we need special for a woman with mental disease, that they need to sedation for other situation, and we can use the same opportunity to insert the implant. And of course, we have to think and discuss with the woman or with the guardian if it's easy to deal with bleeding unpredictable irregularities. And about the intrauterine device, copper or with hormonal intrauterine device, of course, we have the techniques of insertion. Sedation may be needed, as I discussed before, with implant and the hormonal intrauterine system. We have to discuss that bleeding irregularities are frequent, in special in the first months of use. Sterilization. Sterilization, it's a voluntary decision. We need consent. We need to respect the ethical and legal consideration. Is not forced. The women with disabilities are not forced to sterilization. This is completely against the respect of women's rights. But like the other woman, the use of hormonal methods have health benefits, and the health benefits of hormonal methods are the same for the women with disabilities and the women without disabilities. And we know very well these health benefits, and some of them are very important for the women of disabilities, with disabilities like control of dysmenorrhea, the heavy bleeding menstrual, symptoms of endometriosis, the fluctuations of mood during the menstrual cycle, and this is very important for these persons. Of course, the hormonal methods are very effective in preventing unplanned pregnancy. So we have to discuss with this in this population the need of menstrual suppression. For some of these women, this is a very important offer, and contributes for this quality of life and for the quality of the family that take care of some of these women. So suppression of menstrual is a safe procedure, and it's important for the woman with difficulty in self-care, and is important for the woman with mood disturbance during the cycle. And for some women with disabilities, menstruation is the fact a moment of stress for her and for the families and for the carriers, and menstrual control can be very, very important and an important contribute to the quality of life. So it's safe, it's viable, and we as gynecologists, we have to be active and ask to the woman if she wants, if it's a need, and this is important for the quality of life and for her autonomy. How can you do that? We can do that with a combined hormonal method in extensive regime. It's easier. We can use mainly monophasic formulations with 30 micrograms of ethinylestradiol because the bleeding control is easier. The amenorrhea, it's near 50% to 80% in the first 2, 6, or 12 months of use. The disadvantage is because sometimes we have breakdown bleeding. We cannot use this extensive regime with combined hormonal contraception with people that are not eligible for combined hormonal contraception, and it could be difficult for the users that are family dependent. And for the people who don't want to use combined hormonal contraception, or they are not eligible for hormonal contraception, we can do extensive regime with POP. We have better performance with use of drospirenone in extensive regime. But of course, we have to inform the woman sometimes that unpredictable bleeding could happen. And we can do this with Depo-Provera. And for that, maybe the interval between injections could be lower, could be each 2 months, and it's easier if you do Depo-Provera in each 2 months, if easier to have amenorrhea. But of course, the long-acting methods could be a choice for suppression of menstruation too. We can use the implant is a method for 5 years. Of course, we can inform the woman that irregular bleeding could happen, but the majority of the women they have improved in the menstrual normal pattern, and it's true for intrauterine device with levonorgestrel, and for the suppression of menstruation is important to choose levonorgestrel with 52 milligrams of progestin. Normally we have half of the population will be in amenorrhea in 1 year, and 60% in 5 years. Of course, we have to do, we have the limitation of the insertion. We have to inform that irregular bleeding could happen, but the number of cycles that woman will have bleeding will less than the number of cycles that women have bleeding in a normal with no use of hormonal methods. And if we decide to suppress the menstrual in this woman, that is very important. It's very important to inform, and we have the information. How can we manage the breakthrough bleeding? And we have strategies that we know well, and for the combined hormonal contraception, and it's for oral, patch, and vaginal ring. If we have bleeding, we have to stop 3 or 4 days, and we can continue. And with oral processing, we have to inform that to the woman that they cannot forget and take exactly the pill at the same day. And with the Depo-Provera, we can, if the women are eligible for oral contraception or for estrogen, we can do during 10 or 20 days, we can add to the Depo-Provera the treatment of with estrogen, and the bleeding pattern will improve. And if we have breakthrough bleeding with implant, we can do the same that we do with Depo-Provera. We can use a pill for 1 month, or we can use a patch of estrogen for 10 or 20 days if there are no contraindication to use of estrogen. If there's contraindication, there are some studies with good improvement using POP during 1 month. And it's the same procedure for the woman who have intrauterine device with levonorgestrel. If they experience more frequent bleeding or bleeding for a heavy bleeding during the use, we can try to use estrogen, or we can use other kind of medication like anti-inflammatories, non-steroids, or a doxycycline. And the majority of the women will have improved and good results in the bleeding pattern. So we cannot forget that the persons with mental and physical disabilities, they are not forced to use contraception. They are not forced to have menstrual suppression. It's a question of choice, and we have to use clear language to obtain the consentment from the woman. If it's not possible, we have to discuss this with the parents. And if it's not possible, discuss this with the parents. We have to support us from the legal system of our country, of our city. There's good guides for information for women with disabilities about their rights and about their rights. I find this is a very nice guide for design to women with disabilities, was done by Judy Reyes, and they have a lot of information about rights, about contraceptive methods, about the advantages of use contraception. There's a lot of information about for planning the pregnancy. There's a lot of information to support the woman, the persons with disabilities. So we have to, in our countries, we have to improve the information for for the woman with disabilities, and go taking into account the individual needs of the woman. So for finalize, people with disabilities have the same and equal right to highest and standard of health as other human being. The contraception is a choice, and we have to respect the freedom of choice. We have to respect and know well the medical eligibility criteria. We have to train ourselves to individualize communications and use different communication that from the oral communications. We have to be sure that the woman can understand and recognize the side effects that could happen with hormonal methods, focus on benefits of hormonal contraception, and of course, we have to use our appointments for screening, sexual assault, domestic violence, and other forms of violence. Thank you.
Thank you very much, Teresa. Can I just say that we have 10 minutes, and by the way, thank you for finishing absolutely on time, which is really good. So we have 10 minutes for questions, and I'm going to give you the questions that we've had so far. But at the end of the two presentations, we will also have a time when we close for people to ask questions. The second thing I wanted to say, which I forgot to say, is at the moment we have 270 participants, but we have had over 700 registrations for this webinar. So the recording will be available free at the ESC website, and we will also be sending the link to the UNFPA, so it will be available on that website. So a lot of people register because they want to see the recording later. And just in case I forget, I'm just going to use this as an opportunity just to tell you about the next webinar, which is on the 18th of December, and it will deal with two more very interesting topics. So we're going to hear a presentation on women living with HIV in relation to contraception and reproductive health, talking also about the drug interactions, which are very important. And we're going to have a presentation about promoting contraception in low fertility countries. And that is a challenge definitely in the Eastern European and Central Asia region, because some of the policymakers promote pronatalist and, at least in an indirect way, anti-contraceptive policies. And a lot of the benefits of contraception, which Teresa has talked about, would apply in these situations. So we will have an interesting presentation. I'm going to go to the questions and just take all of them. So we had a comment about future topics. So these were suggestions looking at diabetes and neurological disease. So maybe we could expand on the theme from this meeting. We've got thanks from the Patient Fertility Association in Israel. So welcome to the meeting. We have a question which I think requires, or an opinion that requires discussion, and I'm going to read it. It says, there has been a strong push from the disabled community to not use the term people with disabilities and use disabled people ascribing to the social model of disability, that they are disabled by the environment. Could that be discussed? I'm just going to put my penny's worth of this. Obviously, disabilities is in a way a formal term, could be a legal term. I mean, for instance, in this country, in the UK, we have disability benefit. So everybody knows what that is. But I wonder whether Teresa has a view about that.
Yeah, all the documents that I look and I use in my population, and we have to focus our communication in the person. So the person with disabilities is not a disability person, it's a person with disability, and the focus must be the person, because disabilities could be a huge group of population. So we have to focus that the citizen is Anna, she's pregnant, she go to a hospital, but she has a disability. And the focus must be the person, not the population. This is our actual view, to not discriminate the people and not to allocate the people to different groups. So they are people, they are persons with disabilities, and disabilities are completely different. So what Hallie says that in a legal system, we have support for persons with, or for population with disabilities. But we, as providers, we have to focus on a person. This is the first thing that is important for us. We cannot exclude, and we cannot see this person with my patient with disease with autism. No, she's Anna, she's my patient, she needs my support, and she has autism. So it's a completely different approach. And we have to train ourselves in this exercise. Ali, we have other.
Yes, we have other questions. So thank you very much, Teresa. This is the type of discussion that we have on doc matters. So if the person who asked the question can put it in doc matters, you will get opinions from all over the world. I mean, doc matters, you know, we have Argentinian contributions, we have people from Hong Kong and Japan and so on and so forth. Anyway, the next question is, I'm going to just read it. Cyclical mood changes and experience with neurodiversity. Teresa.
Yes, but okay. When we choose hormonal contraception, we can have this impact in mood. It's true, and we have to have sometimes in the persons with disabilities that they have. Imagine, I'm thinking about dysphoric premenstrual syndrome, and like any other persons, it's important to treat these situations, and we can use the hormonal contraception to control and to benefit, to have a medical benefit in the use of some kind of formulation of hormonal contraception. But of course, if there is this need from our woman. If there's no need, it's up to them. It's up to her. It's like we do for the other population of our patients.
Okay.
And the other thing is implant for 5 years.
Yeah.
According with FCM of the medication, the implant is for 3 years. We are discussing about implant now, but WHO and all international recommendation and the most modern studies saying that we can use the implant for 5 years.
Okay.
And
can I just interject? I think on the cyclical mood and changes, just to give an opinion, very short, is that people with neurodiversity, if we think that they are, or if they demonstrate that they are not sensitive to hormones are actually a good way of dealing with cyclical changes.
Yes.
But the other issue is whether they'll be compliant. You need to make sure, for instance, that maybe you use the patch or the vaginal ring if you're going to try to suppress ovulation. That's just one point.
Yes, but sometimes, Hallie, if they have a family support, and I'm thinking in a group of adolescents, if they are using other medication that not interfere with the efficacy of hormonal contraception, we can use it at the same time, and it'll be easier to use this. And about the
implant and anti-convulsive treatment.
Yes. And we know the implant, it's in theory, yes, there's an interaction, but the level of ethinylestrol that we have in implant, it's quite higher than the level of ethinylestrol that we need for suppression of ovulation. So it depends on the kind of medication, and the dose of the medication, and it's safe to use implant in these patients.
Okay, so we have now some suggestions. So Dr. Daz is commending the presentation, saying it's an excellent presentation. So that is really good. Thanks very much. And there is a question about, well, saying that women with HIV, the topic for next webinar is very interesting. So I'm really pleased that we chose it. We chose it actually in collaboration with UNFPA. These are issues that are very pertinent to the region. And the issue about settings with low fertility is also very pertinent to the region. And we have future meeting a suggestion, long-acting reversible contraceptives for men and contragestion. Yes, that is something we want to do. We also have webinars which are not necessarily joint webinars, so we'll need to discuss the topics with our colleagues in UNFPA and see if that is relevant. In a way, it's a priority, so we may come to it eventually, but we will keep that in mind definitely. And this is from BPAS. Julia Ahmed from Bangladesh, so welcome, Julia. So I don't know, can you read, can you see the question, Teresa?
Yes, I can
you want
see
to read it
the
so
question.
that you can answer.
Yes, I can.
Yeah.
I'm reading the question. So, Julia, sometimes in my country we have this kind of problems that the parents, we need to suppress the menstruation, and the parents are not easy, or the parents cannot understand that, or are not available. If the parents are not available, you can look at other person of the family, or if it's not possible, look for legal consentment. And so in the hospital or there's always in a minors legal a group, there's always someone, there's always an open door for this situation, at least in European countries like that. When we have a problem, we have 24 hours at legal at court, and we have a person, a group focus on health and human rights, and we can ask for support and consentment in that way. I hope it's that clear.
Okay.
Yes.
Thank you, Teresa. I'm really keen to stick to time, so we've taken a minute or two from Matthias's presentation. So thank you very much. Can I introduce our second topic and the second speaker? So we have a pleasure in welcoming Matthias Greutmann, who is based in Zurich in Switzerland, and he has extensive experience in cardiac disease, describes as his main interest clinical care and research in cardiac disease and pregnancy, including contraception. And since the year 2010, he's been part of a multidisciplinary program of heart disease and pregnancy at the University Hospital of Zurich in Switzerland. And he's going to talk to us about cardiac disease, contraception, and reproductive health. So the floor is yours, Matthias.
Thank you very much, Ali. Thank you very much for being here. It's a pleasure that I am allowed to share with you some thoughts about contraception in patients with heart disease. My only conflict of interest is that I'm not a gynecologist, I'm a cardiologist, but at least I found out that the abbreviation of our societies share the same abbreviation. So it's also called the ESC. What I'd like to talk over the next 20 minutes, I would like to give you a scope of the problem of young women in childbearing age and the problems of contraception. I will then touch the risk assessment in terms of pregnancy, as well as the risk of contraception, and then highlight some pitfalls and problems with contraception in women with heart disease. And in the last part, I would highlight some non-contraceptive benefits of contraception. So let's start with the scope of the problem. Congenital heart disease is quite frequent. It's the most frequent inborn congenital defect in babies. About 1 in 100 babies is born with a congenital defect, and about 6 in 1,000 babies are born with complex defects. This includes lesions such as tetralogy of Fallot, transposition of the great arteries, or patients with univentricular hearts. And they have all in common that the babies born with these conditions are severely cyanotic, and we know that without intervention, only very few will survive to adulthood. And the survival of these patients has changed dramatically over the last few decades, particularly with the invention of the heart and lung machine and with the invention of surgical techniques for these defects. We expect now that more than 90% of affected babies will reach adulthood. And this is the main reason why we see more and more adult survivors with congenital heart disease in our outpatient clinics and in our clinical practice. But we have to be aware that the majority of these patients are still young. The majority is below 40 years of age, and for women, the majority is in childbearing age. And we learned early that we do not really correct or cure congenital heart defects. We know that these patients have a much worse survival during adulthood due to a number of issues that may arise during adulthood. This is particularly true for patients with complex congenital heart defects. And we also know that the number of patients and the mortality risk may only be the tip of the iceberg. As I told you, many of these patients will face complications, have arrhythmias, need reoperations, may develop heart failure and endocarditis, and the majority of women may wish to become pregnant, and depending on the type of defect and residual lesions, this may be associated with an increased risk. While I think congenital heart disease is probably still more an issue of the global north, there is an important heart disease, the rheumatic heart disease, that is much more prevalent in other countries. So this is a world map of the incidence, prevalence of rheumatic heart disease all over the world. And while in Western countries, in Switzerland, rheumatic heart disease is quite rare, it is a huge global problem. And most women affected by rheumatic heart disease have mitral valve disease, and many are left with mechanical heart valves. So that is the reason why we see more and more women with the heart disease that we follow during pregnancy, and most of these women have complex heart disease and need care by multidisciplinary teams. That's important because we know that heart disease is the #1 reason of death in developed countries for women dying during pregnancy. It makes up about 1/4 of all of the entire mortality in this population. And we know this includes valvular heart disease, but also cardiomyopathies, channelopathies with sudden cardiac death, aortic dissection, and with increasing maternal age in Western countries, ischemic heart disease becomes more prevalent. So when we have to assess the risk of a pregnancy, I would like to illustrate that with this example. That's a young female. She had already had an uneventful pregnancy, and then at the age of 25 years, she developed endocarditis and required a mechanical heart in a new relationship and wishes to become pregnant again. And she asks us, what is my risk during pregnancy? And the tools we have to stratify this risk is, on the one hand, we can think about the lesion-specific risk and about the patient-specific risks. And in terms of lesion-specific risk, the most used tool is this modified WHO classification, which classifies different types of heart conditions and residual lesions in terms of increasing mortality risk and morbidity risk. And I won't go through all of these lesions, but I just want to highlight those lesions that are at very high risk of morbidity and mortality during a pregnancy. This includes women with severe heart failure, with low ejection fraction of the left ventricle, women with poor functional class, all forms of pulmonary arterial hypertension, women with severe mitral stenosis, even if asymptomatic, women with severe symptomatic aortic stenosis, women after Fontan palliation for univentricular hearts with poor Fontan function, women with systemic right ventricles with poor function, and then the aortopathies, Marfan syndrome, women with Marfan syndrome and dilated aortas above 45 millimeters, and women with bicuspid aortic valves and an aortic dilatation above 50 millimeters. These are really high-risk conditions, and usually we recommend that these women not become pregnant. But we also have to ask ourselves, can we modify the risk? For example, in patients with valvular heart disease, we may operate on them, on a woman with severe mitral stenosis, and then she may have a lower risk. And the same is true for patients with aortopathy. We can selectively operate these women, and then they have a lower risk. For all other women, we need to make individualized decisions, and it's very important that we then give the women who do not want to take the risks of pregnancy effective contraception. On the other hand, apart from the lesion-specific risks, there are specific patient-specific risks. In the Western world, the maternal age is steadily increasing, which poses additional risk. We see more and more pregnancies that are came through by IVF. And in Western countries, we have a huge problem with obesity, diabetes, and hypertension. And I think what we've learned over the last decades is that the care for women in childbearing age needs to be a team care. This concerns both preconception, during pregnancy, and the postpartum period. And it's really teamwork. We need different types of specialists to account for all issues that arise in such women. And it really needs a holistic assessment, not only looking in the type of lesion, but also in patient-specific obstetric risks, in risk modifiers such as previous arrhythmias, and we also need to think about the fetal risk with certain conditions. And as I've shown you, these are the pregnancies that are followed at my center, and the majority of these women are women with high-risk pregnancies with a WHO class of more than 2. We also have to be aware that women with heart disease may be on medication that is teratogenic during pregnancy. This includes ACE inhibitors or sartans, patients with cholesterol problems on statins, high-dose vitamin K antagonists, and the novel anticoagulants. So these women who are on such medication, they really need a safe and effective contraception. So what can we tell now this 35-year-old patient with a mechanical heart valve? We have learned a lot about the risk of pregnancy from the ROPEC registry led by Jolie and Rose Hesselink over the last years. And we know from an analysis of the ROPEC registry that there is a definitive risk of mortality, which is about 1 to 2%. There is a risk of valve thrombosis, a high bleeding risk, and only very few women had uneventful pregnancies. And in a patient like that, the conclusion of this paper is that it's really very important that women with an increased mortality and morbidity during a potential pregnancy read very careful counseling, and the care of such women should be centralized. And it's absolutely mandatory that women who do not wish to have these risks during pregnancy will be given safe and effective contraception. So now in the next part of my talk, I will go through the different types of contraception and highlight some specific issues that arise with women in heart conditions. Well, I will mainly focus on the long-term contraception. You may think that vasectomy may be the safest form of contraception for congenital for women with heart disease, and that's really true. But we have to keep in mind that particularly women with very complex congenital heart disease have a decreased survival during adulthood, and male partners may thus survive the spouses. And we are very, very careful with recommending male sterilization in couples where the woman has a complex congenital heart defect. Tubal ligation may be a good option for contraception if there is consent and the woman does not wish to become pregnant, but we have to be aware that the women with the highest risk of pregnancy, this includes patients with pulmonary arterial hypertension and women with operated single ventricle physiology, they may not tolerate well the pneumoperitoneum, and we have to be very careful when planning such interventions. The same may be true for IUDs, which are also a good and safe method of contraception. Again, the same group of patients with women with pulmonary arterial hypertension or single ventricle physiology, they may not tolerate well vagal reaction and may lead to cardiovascular collapse. So what we do at our hospital, if a woman wishes to have contraception with an IUD with one of these conditions, we usually do it in the OR, in the preparation room of the OR, and we ask an anesthetist to stand by and to be ready to counteract vagal reactions if the need should arise. Now the second group, these short-acting contraceptive measures. Here, the combined contraceptive pill may be contraindicated in some forms of congenital and acquired heart disease. And this is true for patients with a Fontan palliation. These are patients who have very often very large right atriums, very large Fontan atriums, and they are very prone to developing clots within the heart, even if they are on anticoagulation. So we are very hesitant to put a Fontan patient on a combined contraceptive pill. Then all patients with intracardiac shunts are at risk of paradoxical embolism. This is particularly true if there is a significant right to left shunt, but even if with ASDs, with predominant left to right shunting, there is a risk of paradoxical embolism, and this needs to be taken into account when prescribing estrogens. And lastly, these older styles mechanical valves, we do no longer see them very often, but they have an increased risk of thrombosis. So we would recommend to abstain from combined oral contraception. So right-left shunts, patients of the Fontan palliation, old mechanical valves, patients with pulmonary arterial hypertension or poor ventricular function should not receive combined contraceptives. Again, in all other women, it needs to be discussed and the decision needs to be individualized. The progesterone-only pill is kind of the Swiss Army knife for the cardiologist in terms of contraception. We can use it basically in all forms of heart disease. There is one thing we should be aware. Teresa mentioned it before. There may be drug-drug interaction, and women with pulmonary arterial hypertension being on this older type medication, Bosentan, there may be an interaction that reduces the efficacy of the progesterone-only pill, and usually in these women, we recommend to use a second method of contraception, either barrier method, or we adjust the dose of the contraceptive agent. And recently, I found this study 2 years ago was published in a large series of women with the long QT syndrome, which can create torsade de pointe and sudden cardiac death. the authors found that there is an association of the use of progesterone-only pills with event rates in women with a long QT syndrome. But this was only true for women who were not on preventive beta blockers. So if you consider prescribing a progesterone-only pill in a woman with long QT syndrome, it should always be combined with the use of a beta blocker. Once we have made the risk assessment, both in terms of pregnancy and contraception, we need to counsel our patients properly about all these risks, about the risks of contraception and also about the failure risks. And there is certainly room to improve. This is a study from Germany where they asked 500 women in the outpatient clinic about their experience with counseling about these sexual health issues. And they found that among these women, 20% received contraceptive methods that were actually contraindicated for their condition. And more than a fourth of women in high-risk conditions in a sexual relationship had no contraception at all. And 40% had no counseling about contraception, and about half of all women had no counseling about pregnancy risk. And that's really, when you look through the literature, this did not really improve over the last decade. So it's really important that we start early with all women in childbearing age to talk about sexual related health issues and contraception. And this should be starting in adolescence, and the primary person who should raise these issues is usually the cardiologist. So it's our obligation to do that. On the last few slides, I would like to highlight some non-contraceptive benefits of contraception in women with particularly congenital heart disease. So this is a patient of mine. She's 45 years old with pulmonary atresia, a very complex heart defect, only palliated with a blalotoxic shunt. So she's severely cyanotic. She's blue. She has a very poor exercise capacity, and she's on anticoagulation for a thromboembolic disease. And she calls me because she has very heavy menstrual bleeding and really feels bad. So, as I said, she's deeply cyanotic. Her oxygen saturations are around 74%. And that's her blood work. Her hemoglobin level is within normal range in our lab. But as you can see on the right side, the iron panel, she's severely iron deficient. And I sent her to the GP for an iron infusion, but then she sent me back this email and told me, well, I went to my GP and asked for the infusion, as you said, but they said, well, you are stupid, your hemoglobin level is optimal, and you won't need any iron. But keep in mind, she's very cyanotic. So with a saturation of 74%, it's the same as you were living in Camp 2 on Mount Everest. So there, a normal person has an oxygen saturation of 74%. And these patients, it's vitally important that these patients have enough iron so that then the body can build enough erythrocytes to keep on oxygen capacity. And that's what we did. We gave her 2 iron infusions, and you can see her hemoglobin level rose to adequate levels, as we see in these deeply cyanotic patients, and she felt much, much better after this. And for such a patient, giving such a patient an IUD that regulates this heavy menstrual bleeding may be one of the most important medical measures for their well-being and their prognosis. Again, keep in mind, these are high-risk patients. If you insert it, ask your anesthetist to stand by and be prepared to counteract any vagal reactions. So in summary, I hope I could show you that there is a growing cohort of adult women in childbearing age with heart disease that need to have contraception. I hope that I could show you that the risk assessment, both for pregnancy as well as for contraception, is really a team effort, and we need to collaborate between cardiologists, obstetricians, and the contraceptive specialists. And sometimes for women with heart disease, particularly cyanotic women, the non-contraceptive benefits of contraception is extremely important, and communication with the patient and the colleagues is of highest importance. Many thanks for your attention.
Thank you very much, Matthias. So we've got a lot of questions, so we will try to go through them. But I also have a message to the ESC team. Can you look at the chat, please? There is a question at the chat. Okay, so we'll take them from the bottom up so that we get the cardiovascular questions. So the first is again a commendation from Christina Toha saying, "What a great presentation." And another says it's very interesting. Now there's a question about implants and heart disease. What do you think? I mean, in a way, an implant is a progesterone-only method. Would you see any reason why it shouldn't be used in someone with heart disease?
No, I think it's a very good option, particularly for women with high risk of pregnancy. These long-acting reversible contraceptive methods are excellent options, and we have a lot of women with implant-on or also with IUDs. I think these are very good options because often, as I mentioned, the control of menstrual bleeding may be a very important issue in these young women.
Great. Another question asked, why does IVF increase cardiovascular risks? I'm not aware of it, but maybe you can enlighten.
No, it probably does not increase cardiovascular risk, but we have for example, women after the Fontan palliations for the univentricular heart. It's very difficult for them to become pregnant without assistance, and more of these women with very high risk conditions seek assistance by family, by fertilization, and so we see more and more women with very complex heart disease that may then even have multiple pregnancies with the aid of IVF, and also with the use of IVF, we see women at higher age, which then are more prone to coronary artery disease and things like that. That's what we see more and more in the Western countries, that women present with a heart attack during pregnancy because of the higher maternal age and this assisted fertilization.
Great, thank you. And there's a question again there, very technical. What about repair coarctation, I assume, of the aorta and the risk of someone who has a risk of pregnancy? What would you recommend?
So in women with repaired coarctation, we also analyzed that within the ROPAC registry, a relatively large cohort of women, and they tolerate pregnancy very well. There were a few smaller reports earlier on. They reported a higher incidence of hypertensive disorders during pregnancy, but interestingly, in this report from the ROPAC registry, the risk was very low. I think and aspirin didn't even have a protective effect on preeclampsia. So I think in a woman with well-repaired coarctation, the risk of cardiovascular complications is very, very small and very manageable.
That really is very reassuring. I think we've, as far as the cardiac questions, we've finished with these, but can I just make a couple of comments, Matthias, just to balance things. So you've put Cerazette, which is the desogestrel pill, as an option, which obviously is very good. Just to say that there is another ovulation suppressing progesterone pill called Slinda, which has drospirenone 4 milligrams, which Teresa mentioned. And just to we otherwise will say we are promoting one rather than the other. So Slinda is also a good option with actually a more potent progestogen. And I'm really grateful to what you've said, that, for instance, in the case with pulmonary atresia that you've described, if you are using fitting an intrauterine device, you need to have an anesthetist just to deal with vasovagal attacks and that sort of thing. So they need to be done in hospitals, I assume.
No, we do it as outpatients, but we usually do it in this preparation room of the OR.
Yeah,
kind in the living room of the anesthetists.
so
we give them an IV line, and we ask the anesthetist to do it in standby.
Okay, so it wouldn't be done in an office somewhere where there is
no. Yes, that's the data. So in these women, we really recommend it to do it in a monitored space.
Fantastic. And I'm just thinking of countries where perhaps people work in isolation. I'm assuming that you would be using sort of, multidisciplinary team meetings, shared care between the gynecologist, the cardiologist, maybe the anesthetist, that sort of thing. Can you say a few words about that?
Yeah, I think it's very important, particularly in the care of women with more complex heart disease. For example, like a woman with a mechanical heart valve during pregnancy. This really needs a very good planning. You need to determine the strategy in terms of anticoagulation with vitamin K antagonists versus low molecular weight heparin, and then you really need to stick to your plan and to the frequent checks. And there we learn a lot of our colleagues from Turkey, for example. They made excellent papers about their experience with these mechanical heart valves during pregnancy. But you always have to prepare for a plan B and a plan C and a plan D if you care for such complex women with such complex heart defects. I think that's very important, and you need to establish kind of a centralized care. You need to collaborate also with local hospitals and to provide these tertiary care for these women.
Yeah. And I think I find them really educational for everybody. So I would very strongly encourage colleagues who may be working in isolation to explore with their local hospital, with the specialist, whether, for instance, even if it happens once every month or every 6 weeks, where cases are being discussed. It's a good learning exercise and sharing responsibility and actually doing the right thing for the patient. The last comment I have is, well, 2 comments. One, I think I would second your opinion, which is vasectomy is the best contraceptive for women with cardiac disease or other complications that are significant. But you also talked about tubal ligation. And we gynecologists now recommend that women have tubectomies. They have their tubes removed. Obviously, they have to be discussed. It has to be discussed because that is a sterilization, but it reduces their risk of getting ovarian cancer in a significant way. So put the two things together. We're absolutely spot on time, but I wanted to just go through the other questions and comments so that we deal with them, because we couldn't deal with all of the questions. So I'll come to all of them, but I want to just go to the questions from the first session. We've got a greeting from Rosa Lucia Alvarez Mercado. Buenos dias, and I think she's talking about adolescents, and I hope that we did have a session, a webinar on adolescent contraception, but we will hopefully address that as well in the future. That was one query. I think the issue around the implant being effective for 5 years, there is a request for resources. So we will find a reference and we will put it, usually we'll put it definitely on the doc matters, but we will
WHO family planning, the last WHO family planning talk about it.
Right. Okay, so that is, I think, important. We will also hopefully put a resource on the use of hormonal IUDs, the 52 milligrams, i.e. Mirena type hormonal devices with license for 8 years. We will also put some resource there. You can definitely access that from the Faculty of Sexual and Reproductive Health in the UK from the Clinical Effectiveness Unit. FSRH.org, and it's free. You can access these documents without needing to register or anything like that. And obviously, the license for Nexplanon for implants, I don't think, Teresa, the companies have changed the license. This is more of an expert opinion, which is a consensus among specialists. Is that right?
Yes, the company, in the papers of the company, is written 3 years. There are studies going on to change the paper of the medication, but for now the company assumed the 3 years, but the WHO family planning for health professionals, all the papers, and we can assume the 5 years.
Fantastic. Thank you very much for that. There's a question asking us, we're happy to answer, who is the speaker for the next webinar on HIV and contraception, and when will the webinar be? So again, to repeat, it's going to be same time of the day, but it's on the 18th of December. So it's in exactly the same date as it is now, the day. We have asked Chelsea Moroni, and I don't know whether she's on this webinar. So Chelsea is a fantastic expert on HIV, works in Africa, and has also links to the Clinical Effectiveness Unit of the faculty. She hasn't yet confirmed, so we're waiting for confirmation. And just to give you an idea about the second presentation, which is the promotion of modern contraception in settings with low fertility, Bernard Elbaz from Turkey is going to do that presentation, and indeed it's one of the topics that she is interested in. There are a couple more questions, and we've got a couple more minutes. There is a question that I think we will deal with because it is important, which is for Teresa, and I can help. It says, can you explain better how I can manage spotting on the COC? Do I stop it if the patient has the, and then she says, do I stop it if she undertakes a surgical intervention? So 2 questions, as a matter of fact.
Yes, if a patient will have a surgical intervention with immobilization, it's better to stop the COC 5 days before. But in fact, by routine, in this kind of situation, you use preventive anticoagulation, but it's better to switch the COC to a PO regarding the thromboembolic risk. Another thing that we have to clarify, Hallie, because there's a confusion about it, is about interaction with implants and antiepileptic medication. Of course, it's dose dependent. If you are using a low doses of antiepileptics and you are using an implant, you can be the implant is effective. If you are using a high dose of antiepileptic, you have to care about interaction. But if you are using a low dose, is okay.
Great. I think in the UK, when I talk to our anesthetists for people having an operation, if you think the immobilization is going to be 30 minutes or longer, then you need to stop the estrogen-containing contraceptives. For instance, for a laparoscopy, which usually takes under 30 minutes, you don't need to do that because there is no significant immobilization, and the patient will probably be walking.
And depends of the kind of surgery, because gynecological surgery the risk of the embolic risk are very high. So it depends of the kind of surgery that we will do.
Yeah. And as a matter of fact, there is a comment exactly to say that.
Yes.
Let me just see if there is any other question. I think we've answered all the questions, which is a good thing. We'll have to get you the resources. So I want to finish by, first of all, thanking our two distinguished speakers, Teresa and Matthias. We had a really fantastic presentation. To say that you can always go back and look at the recording, both on the ESC website and on the UNFPA platform. I want to thank Yuri for the interpretation. I hope we didn't go too fast when we were speaking. Tamar, my co-chair, which will close the meeting in a minute, I hope, just to thank her and to hopefully hope to see her again. We will be chairing the next webinar on the 18th of December. Tamar, do you want to say something to close?
Thank you very much, Dr. Kubba. First of all, I'd like to express our deep gratitude to our distinguished experts for fantastic presentations. I believe all participants enjoyed these presentations, and this information was critical for every service provider and every woman we serve. Again, many thanks for fantastic webinar, and we'll look forward to meeting you again in a month.
Excellent. Well, thank you very much for helping with the chairing the event. Ria is also with us. Is there anything else we need to say to the audience, Ria?
No,
we're okay.
With this last slide. Thank you.
Excellent. Well, we've had a very interesting session. So thanks to everybody, and we wish you whatever it is, a good evening or a good morning, depending on where you are in the world. And we hope to see you on the 18th of December.
Thank you for excellent moderation, Dr. Kubba. Thank you very much.
Thank you.
Okay. Bye-bye.
Bye.